So this session is actually divided into two small parts, and we thought rather than have didactic lectures, we'll put up situations and have a sort of panel discussion to get a feel of how we approach children with glaucoma. So the first part is going to be on diagnosis and evaluation of childhood glaucoma, and the second part is going to be on management. And from the panel, I can see Sushma is here, and why don't you join us here only? Sushma's here, and Sunita will join us soon, and Devang is here, and Gazella is here, right? So Sirisha will spearhead the discussion on the part one, on the evaluation, and we'll follow that up with one on management, which is 40 minutes for the first one and 35 for the second. So it'll be quick, 5 minutes per question, and let's see what we have. So Sirisha, all yours.
Thank you, and thanks for all the audience who have stayed back for this session. Yeah. So I'll just be taking, so this part we have divided into two. One is on the definitions and diagnosis and investigations and the evaluation for the diagnosis of pediatric glaucoma. The second part will be on the management. So this will be the brief outline. How do you diagnose a childhood glaucoma? Best way to measure intraocular pressure in children? And what do you understand from the cloudy corneas that are present at birth, and are all of them glaucomatous, and how do you differentiate it? How do you understand whether the child's glaucoma is stable or it is progressing, and how do you infer the changes in refraction and the other parameters for progression of childhood glaucoma? So this is something that I think all of us have to be on the same page. The definition of pediatric glaucoma. What do you mean by, so when you say primary congenital glaucoma is divided into a neonatal onset of primary congenital glaucoma and an infantile onset. So just to clarify, on the neonatal onset is from at birth until 1 month of age, and infantile is beyond 1 month until 2 years of age. This is something that is again very different, because earlier it used to be, at least what we've learned from Dr. Mandal, is up to 3 years of age is infantile. But I think with the recent definition, it is from 1 month to 2 years, and juvenile is 3 years and above. So is there anything that we need to modify for our country, or is this a definition that we all agree on?
Yeah, so what about the 2 to 3 years? You know, would it fall into the infantile, or suppose the child is 2.5 years? It's somewhere in between infantile and juvenile.
Or yeah.
So
that
there
is
was
2
one
years,
term called
2
late
years,
onset.
more than 2 years to teenage, yes.
And I think it's more than 2 years to 40, because
40
is what CGRN says, and so that above 40 it becomes POAG. And Julie, to answer yours is between 2 to say whatever 20 years, or the late onset PCG versus JOG depends on the ophthalmos. So if you have ophthalmos, it sort of indicates that the pressures were high before the child was 2.5 to 3 years, and that's why it's a late onset PCG. I guess that would be how we would differentiate an infantile onset PCG from a late onset PCG. But if there's no ophthalmos at all, no Harp stray, nothing, then say that 7-8-year-old child might be an early JOAG. Is that the usual
thing? Yeah, so
thing?
one point possibly because this is a CGRN definition, you would agree, but then for me, it looks like infantile should be up to 3 years, because you are looking at whether the eye is expansile or not, right? So if you say until 3 years, then possibly it falls into that category, then it becomes easy for you to differentiate the typical JOAG that you would see later. Dr. Mandal, Dr. Ramanjit?
Yeah, if you read the older textbook, it is the cutoff years wise 3 years. New Orleans Academy of Ophthalmology had published a series, from that we know. The recent consensus meeting held, I think, 2013 in Vancouver, it was the classification decided up to 1 month is neonatal onset, infantile is after that to 2 years, and then 2 years, more than 2 years to teenage years is juvenile. Whether you make it 2 years or 3 years, it doesn't make much difference. It's the question of your understanding that when you are deciding, evaluating a child, that yes, it is glaucoma related to developmental abnormality or goniodysogenesis. That's very important.
I think the other thing that has gone off from this particular classification is this developmental glaucoma, because juvenile glaucomas, present almost like open angle adult glaucomas with maybe a very mild sort of goniodysogenesis. While there are a lot of patients who will have goniodysogenesis, but not present with large corneas and other things. So there was that little in-between thing of developmental glaucomas, which would have taken care of this 2, 3, up to say almost 6, 7 years. That seems to have been sort of lost completely. But I think that is something to keep in mind, that you can have the developmental problems of similar to infantile glaucomas, but not have raised or enlarged corneas. And therefore, that tells you there was a developmental problem which maybe either sorted itself out, or there was a forme fruste which sorted itself out, and you have the remnants of whatever there is to treat for the rest of the life.
Yeah. Thank you so much. But I think it's very important. Sushma has a point to make.
I think as ma'am was telling, earlier we had that anatomical classification separate and the age-related classification separate. That was sort of taking care of these issues. Now, since we have only one, so those gray zones would remain, that whether it is 3 or 3.5 years and we still have HAPS-TRI, then what do you do? And if you have a 2.5 but no HAPS-TRI and no corneal enlargement, so those gray zones are going to be there, I think. Because
so I think that is what Sushmita was talking about, that if you have an enlarged corneal diameter and then there is elevated, with or without elevated intraocular pressure, that means this eye should have had an expansion much earlier than 3 years of age. So if you want to say 2 years is a cutoff, whatever, but that would be a late onset PCG, which did not present with the typical features of primary congenital glaucoma or the congenital neonatal onset or infantile, but later, but has a HAPS-TRI. So that is one group where possibly it is not there, but it is the late onset primary congenital glaucoma, late onset PCG. Why these definitions are important? Because especially when you want to do some research or studies, or if you are referring to something, if you are not on the same page, then I think it becomes very, very confusing.
So ma'am, the age for late onset PCG would be 2 to 3 years?
Late onset PCG is about 2 years, and at so beyond 2 years, but you have the features of enlarged corneal diameter and HAPS-TRI. Yes.
I think one of the reasons why they came up with this classification is to try to get everybody on the same page when it comes to research and to publications. But there will be gray areas in between, and as far as management is concerned, I don't know whether it really makes any difference to divide them up into so many categories.
So far management is concerned, it's the question of you are dealing with megalocornea. Isolated megalocornea without glaucoma is a definite entity, we'll have to remember. And spontaneous cure of, rarely, spontaneous cure of glaucoma is a possibility with megalocornea. Typical feature, somebody will tend to operate on the eye, but evaluation may reveal that it is not associated with glaucoma.
Yeah, so there are these features which are confusing. So there are several mimickers for glaucoma, whether it is isolated congenital megalocornea, or you have other conditions where you have zonulopathies with lens abnormality and enlarged corneal diameter, which is not typically primary congenital glaucoma. So they all fall into the category, if they have glaucoma, they fall into the category of secondary. But if they do not, then we should be very, very careful not to touch these eyes and not to operate them for glaucoma. So that is it's very important to differentiate. So coming to the secondary glaucomas, so primary glaucomas, I think we are clear. Secondary glaucomas again are classified into these categories: glaucoma associated with non-acquired ocular anomalies. So that means basically they are developmental anomalies. Those associated with systemic disease and or syndromes, and those associated with the glaucoma following congenital cataract surgery, which is a separate category altogether, and glaucoma associated with acquired conditions. Again, this classification is something that we can try to put them into majority of the glaucomas into these categories sometimes, but there are some gray zones that are there, so we need to understand them as well. So is there any comment on this, or anybody wants to add or have difficulty with?
I think Sirisha and I had this little bit of a discussion, because here for the CGRN, I think it comes from the West. They do not see as many congenital glaucomas as we see, as Dr. Mandal would see it. So for them, the first likelihood is after cataract surgery. So we should not accept this as, you know, something that we see here. In fact, for us, probably all these congenital problems should come a little bit higher, and that may come together with all this other systemic
So would it be included in acquired?
Yes, yes, absolutely. I think, I mean, this doesn't make sense for us at all.
Yes. Post-surgical, so like all other post-surgical glaucomas are in acquired, so glaucoma following congenital cataract surgery can be clubbed to an acquired category as well.
So some of these eyes may have dysgenesis of angle. So if there is already pre-existing dysgenesis, so what category they will fit into? Because it can be, you know, secondary to dysgenetic, and especially if you operate it before 6 weeks of age. So you are already, the angle is dysgenetic, and you are creating a lot of inflammation, a lot of cytokine release, and that has aggravated and, you know, making it manifest even faster. Otherwise also these patients can develop glaucoma because of dysgenesis of the angle.
No, I'm just looking at that CGRN, you know, that classification actually makes any of us who see, say, 100 patients of congenital glaucoma, all right, 100 children who come less than the age of, say, 1 year. How many of them are likely to have had a cataract surgery?
Yeah.
Maybe one, maybe two?
Yes.
All right, the rest of them are the ones we should be concentrating on. So just because somebody else has told us that, you know, in the West we largely do cataract surgeries and therefore they are developing glaucoma, we don't see so many familial congenital glaucoma. Therefore for us, the majority or the major thing should be to look for cataract surgery. I'm just saying it can happen, just put it down. As far as we are concerned, most of the children we see less than 1 year of age have congenital problems. Those are the ones we should be concentrating on and treating, as has been said, appropriately.
Ma'am, just playing the devil's advocate a bit, I think the idea in the consensus guidelines why they put cataract surgery there was to emphasize on the EUAs and the number of children who were being missed, because somehow looking for glaucoma is not in the radar of a congenital cataract surgeon.
Not in the radar
And
of
so
the West. You keep looking at this from the point of view that the number of people who sat on that committee, how many of them came from Saudi Arabia, came from India, came from other places where we see largely congenital glaucomas.
Ma'am, the other thing is that I think here it's even less on the radar. And our cataract surgeries, children following cataract surgeries come to us at 7, 8, 9 years of age when the damage is done because they were not looked for.
I'm not saying don't take him, don't put it.
So I think that's the reason it was put separately, so that
if you look at that
it.
classification, the only arrow that goes first to cataract surgery and then comes down saying no, then you start thinking of congenital anomalies. Look at that classification. It's really a weird classification. It should actually say raised corneal diameter, IOP, put 3 arrows. Say, okay, cataract surgery, say, okay, congenital glaucoma, say secondary glaucoma. Why that one arrow that says, unless you rule out cataract surgery, nothing else comes into the picture? Look at that classification. I mean, it's a really badly made
Yeah, no, we agree with you. So it's not that it should not be there, it is important, but then why that is given more importance compared to the other ones. So we do agree that acquired, whether it is trauma, whether it is steroid induced, is possibly the priority for us as compared to glaucoma following congenital cataract surgery. So it will be a separate entity, it should be a separate entity, because tomorrow you want to compare your data with someone else. So you need to possibly have it as a separate line, but yes, as a part of your secondary glaucomas, but maybe lower down there, because the other secondary causes are far higher in India. We know that trauma and steroid induced are a huge problem that all of us face with.
And one more thing, I just wanted to clarify, as Dr. Sunita Dubey said, that if you already have an angle dysgenesis and then you see glaucoma after cataract surgery, where would it fit? I think it should fit in angle dysgenesis rather than into cataract related to, glaucoma related to cataract surgery. Because when you already have a cause, then you're not looking at secondary to cataract surgery. I think that's what you were trying to.
So you mean to say in congenital rubella and things like that?
No. There are studies which suggest that after cataract surgery, when they studied the angles were found dysgenetic, and especially these dysgenetic angles are more prone to develop glaucoma if the cataract surgery is done earlier, less than 6 weeks or 2 months of age, because these angles, these eyes who have immature uveal tissue, they release a lot of cytokine and multiple factors. It is not just angle dysgenesis, but that EMT phenomena and all which happens after cataract surgery. I think that can lead to glaucoma.
So I understand where you're coming from, but I don't think
I think when they talk about glaucoma following cataract surgery, they rule out all the other conditions in which there is an angle dysgenesis which can precipitate glaucoma in these eyes. All those conditions have been ruled out, and they include only PHPV in that category of glaucoma following cataract surgery. All the other conditions, Loewe syndrome, exactly, are ruled out. So they're two separate things. Maybe that's why they've highlighted glaucoma following cataract surgery as a separate category, entity by itself.
And just one point more, Sunita, many of these angle dysgenesis, if you see and you follow them up, might never develop glaucoma. You have a subset of angle, even Axenfeld, all of them don't have glaucoma. So we're not sure if the cataract surgery was not done, whether they would ever have glaucoma. So I think if you have a child with cataract surgery and a 0.9 cup, even with the dysgenetic angle, I would possibly say that maybe cataract maybe they would have had it without, but given what we have, we don't know that.
Anyway.
But the practical problem is, in a patient with that kind of situation, how many patients has been evaluated meticulously to rule out the angle dysgenesis?
Yeah.
That's the question.
Yeah. No, I totally agree. So how many of us actually do a gonio and then evaluate and follow up?
I think Dr. Vijaya says she has started.
No, we have formed a protocol because we found that a lot of our patients with cataract surgery done at a very young age develop glaucoma. So after that, we formed a protocol that every child undergoing cataract surgery has to have a baseline evaluation first. So the kind of baseline evaluation which is done for congenital glaucoma cases is performed for cataract cases as well, so that we have an idea who's likely to have a higher risk, and those patients are informed and asked to come for a follow-up. So I think that's extremely important.
Yeah. So this is an information that's coming out that every single patient who has congenital cataract who's going to be operated needs to be evaluated as meticulously as congenital glaucoma, not just evaluating the anterior segment for the cataract and other iris changes and things like that. A gonioscopy, looking at the angle, and if possible a photo documentation is something that would be necessary in these patients, and they need to be followed up as well. So Sushmita, would you like to take this? These are the classical features that you see in primary congenital glaucoma. So would you like to highlight the points?
Yeah, well, I mean, that's true. What is the question?
So the question is, do every congenital glaucoma needs to have all of these features?
No, not at all.
Yeah.
Not at all. I mean, a cloudy cornea could be a corneal dysgenesis, a CHED or something else. No, so megalophthalmos could be megalophthalmos without glaucoma as well, and megalocornea could be that. Megalocornea usually, I would say, if the cornea is large enough, then it's likely to be, and if it's clear, then we have that entity of LTPP2, which we need to keep in mind with or without glaucoma. Photophobia, watering, and cloudy cornea with glaucoma is usually one subset. It's that three of them are together, but it's not necessary to have one or two or either.
Yeah. So you may, or I have specifically not added intraocular pressure in this. Intraocular pressure is important, but when you have somebody with a cloudy cornea, a corneal edema, and a HAP striae, and has a corneal diameter which is greater than 12 millimeters, and you have maybe the pressures which are in, let's say, 10 or 12, it still is glaucoma. So I think we have to understand that in children, with raise in intraocular pressure, there are several other changes that happen in the anterior segment. All of this has to be taken into account. And what you rightly said, that if you have enlarged corneal diameter, that is 13 millimeters, so at any age, you have an age cutoff, you have the cutoff of the corneal diameter of 13 millimeters. Anybody at any age beyond 13 millimeters is abnormal, right? So if somebody has a corneal diameter that is 13 millimeter or 14 millimeter, does not have a HAB striae, please think. Please think is it congenital glaucoma, are you dealing with something else? It could be congenital megalocornea, it could be megalophthalmos, it could be a condition which is associated with the zonulopathies with LTP2 mutation, where you have possibly an abnormal ciliary zonules, as well as the ciliary body and the ciliary ring, which developmentally itself is abnormal, and hence it is enlarged, and hence your cornea is enlarged, and it is not, the corneal enlargement is not secondary to your raised intraocular pressure. I think these two need to be differentiated, and all enlarged corneal diameters or megalocorneas are not congenital glaucomas.
There was the first word, megalophthalmos. So is it interchangeably can be used with ophthalmos? What's the difference?
So ophthalmos, typically you use it only for glaucoma, right?
Yeah. So megalophthalmos includes both enlargement of the cornea.
So it's an enlarged,
like enlargement of the cornea with the enlargement of the
entire globe. So
right.
that means you have an increased axial length,
Right.
as well as enlarged corneal diameter. Yeah, Dr. Mandal, would you like to add anything?
Megalocornea, in clinical evaluation, we may say, oh, a very strong suspicion of congenital glaucoma. Sometimes megalocornea, a manifestation of keratoglobus. It's a very interesting presentation. From the distance, somebody will say, oh, he's a congenital glaucoma. Actually, evaluation will reveal something else, like keratoglobus.
Yeah, so any questions regarding the diagnosis? Anybody else wants to add anything? Yeah, let's move on then. So
I think ophthalmos basically means a cow's eye.
Yeah.
So it is no longer part of what we would actually describe as, clinical sort of details or anything else. I think it's
It is
no longer applicable.
It is just a description. The eye looks like ox eye, ophthalmos. But it doesn't mean, the very term ophthalmos should be actually, we should avoid using that.
Along with the enlargement of cornea, it is basically the enlargement at the limbus, and that limbus stretching, I think, so that is, and that we realize when we operate, and that is why I think sometimes if you end up making a small flap, then it's difficult to identify the Schlemm's canal. So limbal stretching, I think.
Limbal stretching is, yes, very important. No, the point that I wanted to drive home is that every enlarged corneal diameter is not glaucoma, and if you have an enlarged corneal diameter without a HAB striae, please do not diagnose them to be congenital glaucoma, and do not do a glaucoma surgery. Evaluate them, understand what the problem is. Is it only an enlarged corneal diameter, or often these eyes are associated with zonulopathies with a subluxated lens or a spherical lens, so that could be a completely different condition. So I think that is something that we need to differentiate, and also to drive home the message that intraocular pressure is important, but when you have all the other features that are there, even with the IOP of 8 and 10, or I'm just throwing a number there, which is possibly in the normal range, you will still consider that as glaucomatous, and you will go ahead and do a glaucoma surgery. So moving on to the evaluation, and which tonometer is recommended in the clinic and under examination under anesthesia. So Sushma?
Well, even in the clinic, if I'm able to, there are a lot of children who are quite cooperative and we go ahead and do Perkins, but yes, in routine pediatric OPD, eye care is the most common thing that we use. When it comes to examination under anesthesia, of course, the Perkins comes first. You can use tonopen as well as eye care, but ideally speaking, Perkins is what I would rely on.
So how many people use eye care in the clinic and would depend on the eye care intraocular pressure to decide on whether to treat or not to treat? Show of hands, please.
Only in very small babies. If the older children, it would be a Goldman. If
Yeah.
they can.
So if you get, let's say, an elevated IOP, I'm just throwing a number, 24 millimeters of mercury IOP with an eye care tonometer, and the child was cooperative, not squeezing. So would you decide on treating, or would you decide on taking it up for an anesthesia examination?
Of course, taking up for the anesthesia examination. Eye care is maybe for screening. If we are getting a normal IOP in uncooperative patients, we may not subject that child to examination under anesthesia if other parameters are all right, but not treating on the basis of eye care readings for sure.
Yeah. Anybody would like to defer?
I agree with them, but I just have one point. See, in our glaucoma department, we do use the Perkins in the OPD, but our pediatric ophthalmology department, we insist that some attempt at measurement of IOP is required. So they use the eye care and then refer patients to us if there are borderline IOP recordings. So some attempt at IOP measurement needs to be made in the outpatient clinic, even in the pediatric ophthalmology department.
That's what
Yeah,
we
so for a
practice too.
serious diagnosis and management and follow-up, you would use a Perkins or a GAT, which is the gold standard even for children. And in the OPD, while screening, rather than a digital estimation of intraocular pressure or a finger estimation of intraocular pressure, you would want to do an eye care and if the child is cooperative, if the intraocular pressure range is from the study that we have done, 19 millimeters or less, unlikely that the pressures would be higher with a GAT, and if all the other parameters are normal, then you may not want to subject them to examination under anesthesia. Otherwise, for serious decision and for management, yes or no, and how you go about assessing whether the pressures are controlled or not, you would want to do with a Perkins or with a GAT. Is that clear? Yeah.
How many of you are using the tonopen for children?
No, we don't.
So everybody has stopped
Yeah.
because we found that the agreement is really poor.
Really poor.
So I think we practically stopped using the tonopen in the glaucoma
Yeah.
department.
No, the issues with calibration as well,
Yeah.
and then
Major
even and you also to get those disposable sleeves was a problem. So we've stopped using tonopen.
I'm only using it for patients with corneal infections and checking intraocular pressure because those are disposable sleeves just to get an estimation and treating secondary glaucomas with that. But other than that, not really.
Yeah.
Not very relevant.
Yes, Julie.
Can we reuse the probe of the eye care tonometer after cleaning it with alcohol sponge? Because that's what we are doing
So in
currently.
India, we don't throw anything, right?
Yeah, we do. What we do, I don't know, Sirisha might differ. What we do is that we then, after doing that on an alcohol swab, just fire it once or twice and then use it in the next one.
Yeah, so that's what we do also. So in a day, so we don't reuse the probes on a different day. So this morning, if you open 5, 10, whatever number of probes that are there, after we use, the eye care pro is what we use. Once we finish testing, before putting it into that small little plastic box that you have, immediately you need to hit it on the alcohol swab and then let it dry, and then you can dislodge it into that box and then leave it there, and then we use it maybe after 5 patients or 6 patients, whenever you want to do that. One thing which we should avoid doing is holding the probe and trying to clean this. So if you do that, then the metal that is there at the back is going to be affected. So even if you have a small misalignment, then your readings can be seriously erroneous. So sometimes we see that from the pediatric clinic, 40, 50 IOP recorded, and they come to you. First of all, those kids will be cooperative for a GAT. That's a different issue. When you do a GAT, it will be normal. But even if you repeat an eye care, the readings will be very different. So I think that is one. We need to see how the optometrists are doing, or if we are doing it ourselves, we need to be careful as well. So we do reuse, but then we don't carry it on to another day. So we finish using them for the day, depending upon what your volume is like. Kavita would like to add something?
Ma'am, I have a question. Like for some babies who are cooperative enough, we are doing Goldman, and probably they might not be cooperative enough on like all the days. Like and sometimes we'll end up in using rebound. So how to analyze or come to a conclusion on interchangeably using all these instruments, which is also like happens in a day-to-day practice. And also I would like to know your panel's opinion on the central corneal thickness. What is the role of central corneal thickness in children? Because when there is edema, they're supposed to have a thicker corneas, and how to consider it, like especially in children who are suspicious, how to go about that.
Very important questions. I think we will take the second question as we go by, but does anybody want to take the first question? How do you interchangeably use the intraocular pressure measurements of Goldman applanation tonometer and the eye care that you can do in the clinic in a same patient at different visits?
As long as they come within the normal range, I think it's okay. But otherwise, I would depend on the Perkins or the GAT readings more than the eye care. And your second question regarding CCT, I think the World Glaucoma Consensus has said that don't take CCT measurements in children into the equation because we don't know really what happens to them over a period of time. If you take glaucoma in FAK and children, they do have thicker CCTs than the pseudophakic eyes, but they do develop glaucomatous damage over a period of time. So trying to adjust for IOP readings with CCT in children, I don't think it's not being done in adults, it shouldn't be done in children either.
Yeah, so for the first point, if I can add, how do you interchange, like I agree with Dr. Shanta that if the pressures, let's say eye care IOP is also less than 20 and it's okay and the child is cooperative, for some reason you were not able to do a GAT today, then that's fine. But suppose with an eye care, so what we need to understand is that rebound tonometer overestimates the intraocular pressure by how much? By a mean of approximately 1.5 to 2 millimeters. But having said that, when you take a mean, you have patients on either sides. Like sometimes you can have a difference of up to 4 to 5 millimeters, and if they're uncooperative, it can be even higher. So if it is in the normal range, you would not worry, but if it is on the higher side, then you may want to ask them to come back on another day, either sedate the child and check it, or you may want to EUA if you think other parameters have changed as well. So IOP is important, but we need to understand in children there are several other parameters that we look at to know whether is there a disease that is progressing or should we take them up for an examination under anesthesia. So is there any cutoff for normal intraocular pressure in the clinics and under EUA? Dr. Mandal?
Yeah, normal intraocular pressure in newborn or within the first few years, cutoff values should not be taken as we see in adult, as we take in adult. I'll say in children, cutoff value in the 15 or 16 millimeter when we are doing, anesthesia should be the cutoff value. 20, 21 with under anesthesia is definitely should be considered abnormal. And of course, intraocular pressure is not the only criteria. You have to corroborate with the other findings of other clinical features.
Yeah, so let me change the question a little bit. Let's say somebody is brought to the clinic or referred to the clinic with 0.6, 0.7 cup to disc ratios, suspected to have glaucoma, and the baby is referred to us.
What's the age? What's the age?
Age is 4 years, and so maybe there is just an enlarged cup to disc ratio, and the child is referred to us, and we are examining the child in the clinic. The child is cooperative. So I just want to know, you don't want to EUA the child, you have done the refraction, everything else is okay, but then if you say this child's IOP is 14, 15, is that okay? So that's the question that I'm asking. No glaucoma, but to rule out whether there is glaucoma or not. And if you say this is the limit beyond which I would suspect and I may want to follow up this child.
The disc cupping is significant?
Yes.
How much?
Significant in the sense, like see, normally the patients who come to the clinic is about 0.6, 0.7. Somebody has seen elsewhere and then they are referring the child to us saying.
I think when optic disc cupping is at that level, I'll prefer to do examination under anesthesia and gonioscopic examination, total evaluation of the child's eye.
Sushma, would you like to add something?
Yeah, actually, incidentally we tend to see lot of large CD ratios because we see lot of patients from Calcutta or West Bengal. So as we see number of adults having high CD ratio, I get lot of patients referred from pediatric OPD that large CD ratio. So if my pressures are around say 14, 15, I would not evaluate them if other things are fine. But if they go in the range of 19, 20, I generally call them again in the clinic And if they are repeatedly high, then only we subject them to UA, because we have a lot of number of patients like that, children coming at 4 years, 7 years, 10 years who are having large CD ratios, but other things being normal. So if the nerve, optic nerve looks okay to me and the pressures in the clinic are say in the range of 14, 15, I would not call them
So
for
less
UA.
than 16 you wouldn't worry, but beyond that you would want to keep a watch. Sushmita?
Similar,
Same. Okay. So that seems to be a consensus that if you see in the clinic, you don't want to unnecessarily evaluate them under anesthesia, but if you see that the ranges are 16 or less and all the other parameters are all right, when you say the difference in the two eyes, there is no difference in the intraocular pressure, the CD ratio is not difference between the two eyes, so there should be no asymmetry between the two eyes, then I think it's fine to say that there is no glaucoma and you may not want to evaluate, but if you think there is something that is suspicious, then you may want to call them back.
Sirisha, can we go on to the next thing? Because what follows, I think we can incorporate in the management,
Sure.
because it's already
Sure.
1 o'clock.
Sure.
So let's go to the management, because some
So
of
there's
these
only one
questions
question
are
we
over.
can take and then we are done. CCT is what. So if anybody wants to add this, while CCT, while I agree with Dr. Shanta that CCT you don't want to really use a nomogram or anything like that, but I think what is very important is if you have a central corneal thickness that is very high and you have a borderline intraocular pressure and there is no myopic shift in refraction and the cup to disc ratio is normal, then I may not want to treat that, especially if it is following congenital cataract surgery. I may want to observe. So I think there are a couple of situations where it would be very helpful for us. But yes, CCT, unlike in the adults, is also something that keeps varying from time to time. Whether it is primary congenital glaucoma or it is secondary glaucomas, it is going to vary. You can also use CCT to understand if the edema is increasing or not. So that also tells you that possibly the intraocular pressure is on the higher side. So central corneal thickness is something that in children is used slightly differently compared to what we do in adults. But yes, it definitely has some role to play.
Can I ask just one question?
Yeah.
So in the last scenario, Dr. Sirisha, my problem comes when I'm seeing a child with a cup disc ratio of 0.7 maybe, and the pressures are not 16 but they're 19 and 20. Then what to do? Should we start one medication?
So in the clinic, 19 and 20, all other parameters being normal and there is no asymmetry between the two eyes, and if the child has been cooperative, then I would follow up the patient. Yeah.
If you see a large cup disc ratio in the child, you can examine the parents. Quite often the cup disc ratio is inherited. So if you see a large cup disc ratio in a child of more than 0.6, which is a little unusual, just examine the parents. That might give you a clue.
Thanks, Sirisha. Can I have the next slides, please? Excuse me? Can we have the next slides? The next set? You can. Is this your laptop? एक presentation होगा? Is it there? Is it there?
Yeah. मैंने choose किया है. You can play that.
Connected with that computer.
You can. Yeah.
Yeah.
So thank you. Moving on to the next, I think Julie, you can come up. Part of the panel. Kavita. Okay, right. So this is a quick 5 questions in 30 minutes. So this is rapid fire. These are the questions that we have. The role of medical management in childhood glaucoma, which drugs and which glaucomas. Is there any best surgical option in a child with corneal haze versus scar? Angle surgery, when and which one? Tubes, when and which one? And when the primary surgery fails, retrab, tube, laser. And steroid-induced glaucoma, which steroid is safe in children? How long is it safe? And suppose steroids are required for other conditions, and what do we do? And the last is glaucoma following cataract surgery, when to do the cataract and how to evaluate children who have had cataract surgery. So we'll go on to the first, whom? What is the role of medical management? I'll take Kavita. She's been quiet. primary, secondary, younger, older, definitive, temporizing. So you'll take them all.
So as far as the primary congenital glaucoma is concerned, and when we are very clear about the diagnosis, it is probably just till we do the surgery, we will be starting them on medical management, probably carbonic anhydrase inhibitors, which are safer in children. And anyhow, the surgery is the definitive
So topical
treatment.
carbonic
topical,
anhydrase.
topical carbonic anhydrase inhibitors. And probably little younger and older children, when it comes to the medical management, again we can prefer carbonic anhydrase inhibitors and maybe prostaglandin analogs and probably timolol, and good to avoid alpha agonist, as we all aware of the side effects of hypoxia, and even in younger children might cause death as well. And most of the time when it is like a primary or infantile glaucomas, it is a temporizing measure, and probably to treat the intraocular pressure, post-surgical intervention, if it is high, again we will depend on the medical management.
Julie, any thoughts on secondary glaucoma? So I've put a VKC there. Secondary glaucomas, would you start with medical or go on to surgery? Would there be a difference?
Ma'am, if the damage is not too much and the pressures are getting controlled with medication, then definitely a medication. But if the glaucoma is advanced and the pressures are not, we are not reaching the target IOP, then definitely a surgery. And one question I had was that, many of the primary congenital glaucoma babies, suppose till they get a UF fitness, sometimes you have to keep them on medications, and they are from outstation, so they don't come back to you immediately. So is it wise enough then to add to a dorzolamide timolol combination a third drug like a prostaglandin, or prostaglandin has no role, and therefore there's no point adding it? Because most of the time we have a tendency कि इससे तो control नहीं हो रहा है और एक दे देते हैं, maybe it will function, maybe it will act, it will not act. So should we add, or should we take a consensus कि इसको add करना ही नहीं है? Dorzolamide timolol में जितना हो रहा है उतना ही होगा, maximum it has no benefit.
Dr. Sirisha,
not oral diamox.
For babies, I mean.
Yeah.
For babies.
Yeah.
We can give oral diamox to babies. Okay.
So if you think, let's say somebody presenting with very high intraocular pressure and really enlarged corneal diameter, and the child is not going to get the fitness for the next 4 or 5 weeks. There are situations like that, right? So in situations like that, then I may add oral diamox. Maximum dose you will go up to is 15 milligram per kg body weight. But of course the child, somebody who's not getting a fitness may have a medical issue or may have a local issue, let's say an NND obstruction and having a problem that needs a surgery. That's a different issue versus somebody with a systemic problem who's awaiting a surgery. I think we need to differentiate the two, and if I have no choice, I don't mind adding oral diamox.
So is there an age cutoff under which you wouldn't and send them off? I mean, we give oral diamox and say, now you go home. So is there a certain age below which you would hesitate to give an oral diamox? Unless they are with you in the hospital or something? Or even a 2-week-old or a 10-day-old?
So it's very unlikely that you will require to give something like that for a 2-week-old or a 1-day-old, but at least I haven't come across a situation like that. But if the child is systemically stable, I don't think there is a problem in giving a oral diamox.
I would be a little wary in the neonate.
How long can you give systemic diamox?
So if the child is awaiting surgery and you want to, if the pressures are really high, see, if first of all, you haven't even started one single medication. So if the child is coming to you already on 2 medications, usually they are referred. Child is already on dorzolamide, already on timolol, let's say it's on a combination medication, and the pressures are still high and the child needs surgery. So you're looking at a situation which is really difficult, and I'm saying in a situation like that, her question is, can we add a PG analog? I'm saying rather than adding a PG analog, I would add a diamox, where I would be sure that you need further reduction in intraocular pressure, and I want to help. So then I would rather not give a PG analog where I'm not even sure whether it will help or not. So that's the situation we are talking about.
Dr. Shanta, PG analog versus diamox as a third?
Again, it would depend on the situation. I think with PG analogs, you get only about a 20% drop in intraocular pressure. So if the IOP is really high and the child has to wait for some time before surgery, there's no harm in starting systemic diamox. But remember that metabolic acidosis can occur, and long-term diamox definitely would avoid.
Be avoided. Devang, anything to contribute to this scenario?
I would agree with Dr. Sirisha. I think think for the interim, if normally the referred patients that come to us, so we are sure that on whatever examination we have done, it looks to be requiring surgery. They're already on combination medicine. I would rather add systemic oral Diamox till the patient awaits surgery.
So Sushma, I'll take this on to, suppose you have JOAG, 17, 18-year-old. Would you medically treat, or if you can control the pressures, or would all those primary glaucomas also require surgery? PCG, we've sort of reached a consensus, everybody needs surgery. What about a young JOAG?
So young GOAG, I definitely give a medical trial. Okay. I don't directly take them for surgery, and I do use beta blockers, carbonic anhydrase inhibitors in them to see how the pressures behave. Some of them do definitely get away with medical treatment. But yeah, quite a few of them land up with surgery, but I don't directly give surgery, unlike PCG where I would not even bother to check.
Wait. Yeah, because say a 17-year-old has maybe 70 years to live and 70 years of medication. I'll take Dr. Mandal's opinion. What would you do for a 15, 16-year-old? Do you plan surgery, or would you first treat?
No, I think trial of prostaglandin can be done, but depending on the situation, depending on the optic disc cupping, field defect, if in that age group it will be possible to assess.
Oh.
And probably you assess and motivate the patient and the parents for surgery.
Okay.
Prepare the patient for surgery. And in the intervening period, you can add.
So you would consider surgery as your first line and give drugs to just buy time.
I'll ask Madam Ramanjit, prostaglandin, at what age you feel comfortable in as addition to other, topical carbonic anhydrase, then beta blocker, and then still some agent is required?
I think if we remember how prostaglandin works, it has to reach the ciliary body. So if we have a very anteriorly inserted iris, as most of PCGs have, then you're not going to actually get anything. Now even 20% is too much. We hardly see any response in primary congenital glaucomas with any of the prostaglandins. But in juvenile glaucomas, you'll find that actually the prostaglandins still work very well, because the trabecular meshwork is still functioning to some extent. The prostaglandins can reach the ciliary body. So definitely, I think a medical therapy is justified in juvenile glaucoma and works, I think, in a fairly large number. What Dr. Mandal is saying is, when the patients come to you with a 0.9 cup, then are you going to sort of think more in terms of surgery than medication? Because as you said, they're going to live for 70 years, and you want low, constant, unfluctuating IOPs.
Yeah, also just to add that the JOAGs typically again behave, I don't want to say like PACG, but they also have quite a bit of fluctuations in intraocular pressure. So sometimes they may be controlled, and then suddenly they may come back, same medications with 40, 50 pressure. So I think they need closer follow-up, and we need to be cautious as well.
Yeah, I think in juvenile glaucoma there are episodic rise of intraocular pressure, and patient may not come for follow-up. So I think a very stringent follow-up is required, and if there is slightest progression or if it's very advanced, then I think surgery is a better option.
Right.
Yeah, can I just ask one question, and maybe since everybody is here who does pediatric glaucoma, so if you see someone with an NLD obstruction, a congenital glaucoma with NLD obstruction, so obviously the plastic people are going to help with syringing and probing. So how long would you wait to do a glaucoma surgery after the syringing and probing? I mean, because people are from different places, and what do they follow?
I think after a week only, because they do
after a week.
NLD, I think after a week they allow us to do surgery.
After a week.
Yeah.
Yeah, it's working.
They start antibiotics in probably, yes ma'am, 2 weeks. Then we can.
So, I mean, just to add this and clarify it, Dr. Shanta, in essence.
Fortunately, it's extremely rare to have this situation. Yeah, they do go ahead with probing and surgery. We wait for at least a week. I do a conjunctival swab, and if it's negative, we proceed with the surgery under antibiotic.
Yeah, so you don't have to wait for 2 weeks, 3 weeks. I think 1 week is more than enough. They call them back, and then they reevaluate, and Usually it is done on the reevaluation as well as the surgery is done on the same day.
Yeah,
So 1 week is... Yeah.
So I wanted to ask, is there any role of the newer drugs, Rho kinase inhibitors in JOAG or as temporizing measure in congenital glaucoma?
I don't know, the redness really puts them off. So I tend to avoid it now. And the younger the patient, somehow I've seen the corneal verticillata more in them for some reason. I don't know why. So I tend to avoid it, but I'd like to hear the panels.
So just a couple of points. So what we have seen in that, for people who have children who have very high intraocular pressures and whose corneal endothelium is compromised, in them the honeycombing kind of an appearance is very, very drastic, and then they significantly decrease the vision, whatever was pre-existing also. So for me, if the cornea is compact and the pressures are high, let's say they are borderline but not really high, and I want to buy some time, then I don't mind using it, especially post-keratoplasty eyes and things like that. The cornea people are more interested in starting them. So I don't mind using it and I don't mind continuing. But in the same person, if the corneal endothelium is compromised, you have a mild corneal haze and the IOP is very high, they're going to come back with, the redness is a problem, they're going to come back with severe honeycombing and drop in vision.
Right, so we'll go on to the next quickly. Corneal haze versus corneal scar. And I'm asking whether any of us would do angle surgery now that we have at least we have a prototype of the eye track as well. So Dr. Mandal, your surgical question is yours. Would you do angle surgery? So these are the three scenarios of babies who've come. Corneal haze, one is corneal scar, and one is a complete edema.
You know, the picture which you have projected, before really deciding what surgery, few important things are to be discussed. The severity of corneal clarity, the severity of glaucoma in general, and the clarity of the angle, if you are planning angle incision, ab interno technique, that is one. And most important is probably the surgeon's own personal experience. What surgical technique he or she is very conversant with or experienced. Person who is very well, I'll say, trained in only goniotomy, probably will not be able to manage the cases which you have shown here. Alternative technique, trabeculotomy, ab externo, and probably the way we have learned from Professor Sood, our mentor, combining trabeculotomy with trabeculectomy is the option. In the milder form of the disease, where corneal clarity permits you to do angle surgery, definitely there is no problem. Alternative to that is probably trabeculotomy ab externo in isolation. The moment it is moderate to severe degree of corneal edema and corneal enlargement is significant, intraocular pressure is high, probably in our situation, in Indian context, I'll say combining trabeculotomy with trabeculectomy is should be the gold standard according to my understanding. My own personal experience I am telling, when in the early mid-90s or early part of the century, when we presented several instruction courses and paper, poster, video, etc., combining trabeculotomy, trabeculectomy, the Western people used to look at this approach very suspiciously. You want to do both the techniques, how it works, and would you like to dilate or constrict? In consideration of when goniotomy is done, pupil is constricted. All these questions came, but people who worked in Saudi Arabia and Middle East country as sabbatical from Western country to this population managing these patients, difficult patients, they realized that probably combined trabeculotomy, trabeculectomy is a very important surgical technique in this part of the country where probably consanguineous marriage or genetic basis is presenting, is acting as a role to produce very severe form of the disease. GAT is, I don't know, I do not have much experience. Sirisa will be able to tell better. You have not written the option. The ab externo, the 360-degree trabeculotomy, microcatheter assisted, illuminated microcatheter assisted 360-degree trabeculotomy is definitely an advancement over these techniques in isolation.
Dr. Shanta, if you can see the angle, okay, let me put in a, if we can see the angle by gonioscopy, then I don't think there's any question about the other two that we have to do a CTT. But if you can see the angle, then what would be
if you can see the angle and if the patient is presenting after the age of 1 month and before the age of 2 years, I think you definitely can try a goniotomy.
Okay. And goniotomy versus GAT?
Goniotomy versus GAT. What I do is, if the patient presents a little late with significant disc changes, I do a external trabeculotomy in the temporal side, because the superior and inferior conjunctiva is not touched. And then I do a goniotomy in the nasal side, so that almost 360 degrees, because microcatheter, you know, we don't have access to it.
True.
And doing it without the microcatheter is difficult. I have tried, and false passages are created quite easily.
Okay.
So this is what I do.
Would anybody else? So we agree that more of the angle treated is better, as much as we can at one go. So there was actually a free paper which was temporal and nasal goniotomy at the same time, just twisting, because the question was that how do you do the temporal side? But these babies have such a flat nose that it's not very difficult to do the temporal also. So that was one. But I find personally the GAT easy. With the suture GAT, it comes out, and even if it gets stuck somewhere, you do a hemi-GAT and you do a goniotomy of the rest, about 270 is done. So that would be my personal, but I'll take, Sunita, sure.
Because I always, in my experience, you need not necessarily have corneal edema or corneal scarring, but cupping can be very advanced, especially when the child has presented late, say 3 to 4 years of age, 0.9 cupping, cornea, you see have stria, but you can see the angle, and corneal diameter is 14 or more. So in that scenario, when the corneal, it's a severe glaucoma. So as the literature suggests that in severe glaucoma, goniotomy doesn't work, although we can see the angle. So in that scenario, I have done goniotomy in few instances, but it didn't work. So CTT was my go-to procedure. So I just want to have opinion of people on that, like, what, if you can see the angle, corneal diameter is more than 14, and CD ratio is 0.9, so it's a very advanced cupping. So will you still do goniotomy?
I would do a GAT.
GAT.
I would do a GAT before opening up conjunctiva and sclera.
But
I would do that.
Plain goniotomy
but then,
will
like
not
Dr.
work.
Mandal said, the first thing is whatever is the best in your hands, whatever the surgeon is comfortable with. The message is that the best that you can do has to be done, and if not, refer ASAP, but not hang on to it.
So for me, goniotomy in some situations, like more than 14 millimeter corneal diameter and things like that, I do it as a second surgery. My first CTT has worked, let's say, for 3 or 4 years, and now the pressure started going up. Rather than a repeat trap and then or a tube and things like that, so these are the last options, right? So then I don't mind doing a goniotomy in them, and even if it is going to as a second, so that will be a secondary goniotomy. It's not a primary goniotomy, and that seems to have effect. At least 50% of the children, goniotomy plus medications, you are able to help them.
So coming on to the tubes, which and when, Dr. Shanta, you'll have to take this. When would you do a tube, and which would you prefer? And when you say which, would you use a ripcord in all or not at all?
We prefer to do tubes for glaucoma and aphakia in children, and in primary congenital glaucoma where two traps have failed. I'm very hesitant to put a tube in a child, a very young child who has a long time to live, because we have had, with the growth, the tube turning towards the cornea and causing a tube corneal touch, and conjunctival dehiscence as well. So primary tube, very, very rarely, perhaps for anaridic glaucoma, when they present at a later stage, but most of the time it is for glaucoma and aphakia in children. And I use an Ahmed valve because quite frequently we don't have a follow-up in the postoperative period, so I'm little worried about the hypotony which may occur at the 3rd or 4th week. So most of the time we use an Ahmed glaucoma valve.
And what is your experience of the high bleb phase and the capsular problem in children?
We start ocular hypotensive drugs within 2 or 3 days when the IOP reaches 10.
10, okay. So that's a message to start an anti-glaucoma ASAP as soon as it reaches 10 to stop. That any differences, first preference, Sushma?
So, if I can just add to that, I mean, from a person who started doing valved implants and then moved to the non-valved implants, especially in glaucoma and aphakia, I would be very scared to do an AGV today. I would do a non-valved implant with a intraluminal stent. So you have much gradual reduction in intraocular pressure rather than, so when you say it's a valved implant, it helps, there is some restriction, flow restriction, but you can have hypotony related problems with that as well.
Well, my preference is AGV only in children. Yeah. I mean, probably my experience is not as much with non-valved implants. And in children, I'm really skeptical about, particularly children with aphakia, to get choroidals and hypotony. So I also prefer AGV.
Have you tried the ACP?
Not yet.
The emetliapath, not
yet.
Sunita?
Yeah. So I have tried ACP, but AGV, my first preference is AGV, but I put a ligature in AGV also.
Okay.
Yeah, so I think that is because I have seen very severe hypotony even with AGV, because it starts functioning straightway and the scleral rigidity is very low. So I think just to prevent last 3-4 times like I have done, and they have done fairly well, especially aphakic and aphakic glaucomas and.
So would you use a ripcord in the ADI all the time?
Yeah.
If you did?
Yes.
Always.
And in ACP it is already there, ripcord.
That's already 30 nylon for
40 nylon, 40 nylon.
For ADI, 40
yeah.
nylon? Okay.
Yeah, 30 nylon or 40. Yeah, proline.
Devang, your preference?
Proline.
Mine also, I normally prefer the valve, but again in patients where we need whether IOP needs to be controlled, where sudden reduction like in aphakics, where I need a longer control IOP, there we have, it's like Dr. Vinay has been doing, and there's a much better control of IOPs over the long term that we are seeing.
Okay, with the AGV?
With ACP.
ACP, okay. Yeah, considering all the AVB and ABC studies saying the non-valves are better for IOP control, so I've converted to non-valve with a ripcord and a ligature. It's not just a ripcord, it's a 3O nylon in the ADI and a ligature over them, and I think our later hypotonies touch would have been lesser, but early days yet. The ACP, of course, the advantage is you don't need to go under the muscles. So it's a smaller thing, and that's the biggest advantage, but of course cost is a factor. 250. I won't use a 350. 250 ACP with the ripcord. Let's move on. Anything else to add? Anybody from the panel?
I thought one
Julie.
important point is if it's a single chambered eye with no iris diaphragm, a pars plana vitrectomy would be required along with the tube implant, because over a period of time vitreous does come and block the tube. I've had a child with an iridia and with lensectomy had been done. About a year later, with the posterior vitreous detachment, the tube was blocked. So now when it is, the iris diaphragm is not there, I asked the vitreoretinal surgeon to do a complete vitrectomy and then put the tube through the
So iris diaphragm is not there in aniridia or
no,
in any?
Yeah, in some, you see some children, no, in which iridoplasty has been done and you don't have a good iris diaphragm in place.
Okay.
Either it is iatrogenic aniridia
or iatrogenic, traumatic, post-traumatic and all that.
Yeah. And even if you put it into the posterior, even the sulcus at times, sometimes we tend to put it in aphakics and pseudophakics in the sulcus. So I tend to do a skirt vitrectomy before putting it in, because even post-vitrectomized eyes I've seen, they might have done a core vitrectomy, but the skirt is still there, which is where your tube is going to be if you put it in.
So you have to emphasize it has to be a total vitrectomy, and they have to excise the vitreous base around the tube.
The skirt as well. Julie, sorry.
Yeah, ma'am, I have 2 questions. Like, first is AGV in children. Like, because we know that the hypertensive phase does come, so is it worthwhile to use mitomycin C? Does it help? Because in the recent child, because of this problem, it's a grade 4 ROP operated, and now she has total cataract and very high pressures, not controlled by trabeculectomy. Then I did an implant. I put little bit of mitomycin C, like 0.02% like in trabeculectomy, and the pressures have been maintained in like 10 now. So is it okay to use mitomycins in AGV? That's the first question. Because one child I did when she was 2 years of age, now she's 5 years. I did in AGV, now she's one-eyed, and the pressures are on 30. So I had to do a TAC, PC 180 degree, like how Shushmita ma'am, she taught us. So, and it really helped. So, so AGV ke saath mitomycins is the first question. Second is, when we if we use an RD implant, like we do, and we put a ripcord suture, so, what's the best time to remove the ripcord suture? Is it 8 weeks, or is it 2 months, 3 months? That was my question.
So the first of mitomycin. Dr. Shanta, would you use mitomycin with your AGVs?
No, I don't use. I think there's one RCT which has been done comparing, with or without mitomycin, and they found that there was no difference. There's a meta-analysis also which shows that there was no difference. And the hypotony-related complications, scleral melts, conjunctival melts, have been described. But I have used it in adults, but not in children.
Anybody else? Anybody using
So if you look at the Moorfields group, I don't think they do any implant without mitomycin. Yeah. So, I mean, what works for you, but if you ask me, is it wrong? I don't think so. If you feel that the fibrosis is going to be quite a bit and it is difficult, I mean, I would actually twist it and say use a non-valved implant. But if for whatever reason you're doing a valved implant, and suppose they're not going to come back, and for you to remove a ripcord is going to be difficult and things like that, you can use, I think. But one needs to be careful about using it and worry about the conjunctiva also at a later. But usually posteriorly you have a very thick tenon, so it's unlikely that if your surgical technique has been good that they may have a problem. I don't know.
So considering the MMC, how the Moorfields does it, they make sure that the MMC isn't in contact with the sclera. So it's put once the valve is put, and then they put in a spear, and they inject the MMC very, very gently into the spear. So the MMC is only between the valve and the subconjunctiva, and they have to make sure that it doesn't touch the sclera. So that's the technique to put MMC between the subtenon space, in the subtenon space, but not reaching the sclera. So that was just one point. And the second was ripcord. I would titrate it to intraocular pressure. I wouldn't take it out all the time. It's far back, you don't need to at times.
Never before 3 months.
Yeah.
Never before 3 months. And I mean, I have a couple of children who are FX. One girl comes from Kolkata. For her, it's been 2 years now. I haven't removed it. Her pressures are maintained at 16 and 17 on one single combination medication. So if the pressures are under control, and if you think for that disc damage it's okay, don't have to remove the ripcord. But I'm very, very scared to remove it before 3 months.
Yeah. Right, so we'll just move on quickly. When the primary surgery fails, Sirisha has told us that she would do a surgery of the remaining angle. Sunita, would you do that? Devang? Surgery of the remaining angle before going in to do a second trab or a tube?
Yes, ma'am. If I've done a CTT and probably it has failed over like 2 or 3 years, I would like to do the angle surgery before going to retrab or any other thing.
So is that a consensus? Dr. Shanta, would you do angle of a surgery of the remaining angle, or you would do a second trab?
I would do a second trab and combine it with treating the rest of the angle, because in the primary surgery we would not have been able to treat the angle because of the corneal phase, and that clears up once the first surgery has been done.
So I just put this up interestingly. This was a patient of a CTT that I did, and I actually did a GAT of the remaining, and you can see in the lower one, if you can, it's actually come out from the original trabeculotomy. So I was very happy with that now we have 360 complete. So this thing has come out of the original trabeculotomy. So that was working. And I've done the 360 as well. So sometimes even a GAT after that is helpful. So, okay. Trabeculectomy, we found tube. Would any of us do a tube as a second surgery? Devang, would you do a tube as a second surgery before giving a trial of another trab?
No, ma'am. I would give a trial of either angle surgery if the corneas are clear, then a retrab, and then keep it as the last.
Sushma?
Yeah, I agree. Second trab, I mean, after angle surgeries, trab and then only tube. Last option.
Sunita, yours too? Very good that we're all scared of tubes in children.
Yeah, I would agree, and except in one situation where there is a corneal haze and the child is awaiting a keratoplasty or something like that, where I would want to put in a tube because you have to make sure that the pressures are under control, plus also worry about the keratoplasty and what the consequences of your angle surgery or your repeat trabeculectomy would be.
So would we
So in
do a
situation like that, I would do a tube.
A primary tube?
No. This is all after the first, after the.
So a primary tube, we've talked of aphakia. Can we bring in post PPV and post PK in that as well?
No.
No, post PPV is also a trap.
Post PK definitely a trap, but post PPV it depends. It depends on what the situation is, and you may have to do a
Because
tube.
the
Suppose
conjunctiva has
it's
already been opened and there is a band and buckle and all that. So would you consider a
so
primary
if they haven't
tube?
if they haven't put a buckle, they haven't really touched the conjunctiva. Then I think even in those situations, if it is a phakic eye, angle-based surgeries also we've done. But if your conjunctiva is touched, or if you have a buckle there and you have done they have done a vitrectomy with oil bubbles there and things like that, it's a really complex eye, I would do a primary tube.
So which PPV would be done without touching the conjunctiva?
No, not necessarily they do the
sutureless.
Sutureless. Not necessarily they do a buckle in everybody and they don't open
just
the conjunctiva.
just vitreous abrasions.
One question can I ask?
Yeah.
Have you tried doing angle surgeries in a silicone oil eye? Does it work?
I haven't tried.
I mean, after they have removed the oil, you have oil bubbles.
I don't.
In children.
No, I mean, once there is silicone oil emulsification, I don't think you can ever clear the angle and the eye of emulsified oil. So I think it would require external drainage. But Dr. Shanta, what would you think?
Yeah, it's not an immature angle which has caused the glaucoma. It's the oil, and it's never going to go away. It's going to be stuck in that superior angle, and it causes chronic changes over a period of time. So I wouldn't do any angle surgery.
I mean, if the oil bubbles are only in the superior angle, would you like treating rest of the angle?
But the rest of the angle is a normal angle. It is not a dysgeneric angle. So I don't know whether I don't think it will work.
So moving on to
Susmita,
yes.
I'm just bringing a theoretical situation. 1 month-old child confirmed primary congenital glaucoma, suppose unilateral. One eye done, surgery, whatever may be the primary surgery, goniotomy or trabeculotomy, failed. You supplemented with, supplemented with medical therapy, and you followed up the patient for quite some time, and you realized that the second surgery is required. When the child is about 6 months old, what could be the approach?
So I think
Trabeculectomy with mitomycin, angle surgery again, or
so I think if the
whatever,
cornea is cleared and the angle
with
is
implant. The reason I am bringing this question, till what age implant should be done very cautiously, because eye rubbing is a phenomena which is very difficult to control. Small child, after the surgery, rubbing of the eye will spoil whatever you have done. From that point of view, I am asking everybody, what could be the age group at which you feel implant is okay, you are very comfortable?
There is no age that we are comfortable actually speaking. But having said that, the youngest I have done a tube surgery is 6 months old. Why? Because the child was requiring trab and trap done, a repeat trap done, failed. Pressure still in the range of 30s and 40s, and they want to do a keratoplasty. So if you don't bring down the pressure, they cannot do a keratoplasty. And again, you can question me, the intraocular pressure estimation in that cornea which is hazy or scarred, is it okay or not? Let's leave that aside. There is glaucoma which is uncontrolled. So in situations like that, I have done, but that is extremely rare.
What about transcleral?
May I request Dr. Ramanjit to comment on that?
Like Sirisha, I think I'm not comfortable with valves at all, because anything in the long term, because when you're doing it in children, I mean, I say this for adults are going to live for at least 30, 40 years. In children, they're going to live for 70 years. So you have to keep in mind that, there are certain things that will work for maybe 2 years, 4 years, maybe even 5 years. But the side effects that actually continue to change, the endothelium, and what Dr. Mandal said about children rubbing their eyes, we did do a fair number of valves at some point, and we found 2 things happened. One is that the tube was very mobile, even if they were not rubbing their eyes. If you asked them to look up, look down, sort of accommodate, you could see the lenses move, the tube move. The second thing was so many of them, the tube actually just came out of the sclera, the scleral opening. They just came out and they were sort of waving around under the conjunctiva, not actually eroding the conjunctiva, but the entire tube just came out. So there are many things that happen because children don't behave the way you want them to. So the rubbing is not only sort of going to keep displacing the tube, it's also going to have some sort of effect on the endothelium. And in some cases, because the sclera is so thin and it's sort of malleable, the tube actually used to sort of come out of the AC itself.
So Sirisha, why not limited cyclophotocoagulation?
So we can do limited
Before,
TSCPs is
rather than
definitely
putting in
a
a tube.
choice, but I'm talking about a specific situation where it's awaiting a keratoplasty. So if it's awaiting a keratoplasty, amount of inflammation that you would induce, and they would want to do the corneal procedure in the next 1 or 2 months. So you do a DLCP and you're not sure how much of pressure control would be there, and would that child be able to undergo a procedure in the next couple of months. So in a situation like that, I don't mind doing a tube, but that is like, I'm giving you a specific scenario, otherwise, no.
So if it doesn't have to do a keratoplasty, one stop short of a tube, can we give a chance
Yes,
of DLCP?
of course.
Before a tube?
Yes.
So how many of us would do a cyclophotocoagulation before a tube? Most of us. So I'm so happy. Ma'am wouldn't. Dr. Shant?
Results with cyclophotocoagulation are really poor. Very, very poor success rates, 20 to 30%. So I would try everything else before going in for it.
Going in. Okay. We've used transillumination now, and our results have really
That is
become
routinely done.
much better. Okay. And ECP, where does that fall in the armamentarium? Aphakic, pseudophakics before a tube? Is it fair enough to do
we
an
have
ECP
done
before?
ECPs earlier, but you have to remember that the curved probe that we use, let's say for an ECP from an anterior approach, is 20 gauge. So in a aphakic eye, if you have to keep the eye filled and go and do this ECP, it is extremely difficult.
No, but you can do it with a straight gauge as well. There's no problem with doing
It's
an
from an
ECP.
anterior approach.
Yeah.
From an anterior approach, it's not easy. It's not easy to do that. You can do that, but the size that you need to use is quite large. So in a situation like that, what we do now, I've done that maybe about 8-9 years ago, but now what we do is, I ask the posterior segment surgeons to do the 360-degree endocyclophotocoagulation, and they are quite comfortable indenting it and doing it. It is their domain, and let them do it, let them do a good job. So I send it to my friend and ask them to do it and send the baby back to me.
No,
I wouldn't take a chance.
Okay, maybe they don't need the vitrectomy. No, they still go in, and you would ask a posterior segment surgeon to
No,
go
in an aphakic eye, even in an aphakic eye, if you want to do, so this is extremely rare. Like in aphakic eye, anyway you won't do it.
No, phakic you won't. I was asking pseudophakic or aphakic eyes. Anteriorly, just tent up the iris, and it's quite comfortable
I mean,
to do
I
it
would
with
rather
two
do
ports,
a limited DLCP rather than doing
because
an
I found the
ECP.
ECP to be far more predictable, because I'm seeing it. And especially if you do 2 ports with a straight probe, it just goes in and you can treat most of it. But anyway, that's part of the thing. Anybody else comfortable? ECP, Sunita? Would no for aphakic or pseudophakic? Okay. Right. So steroid induced is the last. I think we've touched which is relatively safe and which would we not give in children. Which is a safe steroid? Somebody has VKC, would be. I mean, the cornea guys would say we need to give steroids. Lotipred versus FML versus anything. Lotipred. I think Lotipred is okay.
And that is unsafe, but then
but if you don't have it, well, what? And if steroids are required for other systemic conditions, do we actually mandate do not use steroid and use other immunosuppressives for a steroid responder? Should we be doing that? So that's the question.
Ma'am, but then even if we write it,
actually corneal surgeons are left and right advising steroids, and that too high strength, even ointments.
No, this is for systemic conditions.
Systemic conditions.
Systemic conditions, would you be?
Okay.
basically a lot of nephrotic syndrome patients are referred, and although we write it in them, but there are, I think they have an episode of like acute rise or acute something, so they do start, even if after writing, they have to start steroids, although I mean, it's taken care of, but it cannot be totally cut off.
So then what would you do? Do a trab? Because we have an outflow then? How do we manage that? I mean, that's a real problem, because all of these children come we write immunosuppressants and are on call with our pediatric rheumatologists all the time. So when they know that it's blinding, there's no point in, they will call us and say, can we please give it for this much time? So at least we know, we put them on Diamox. But I think with methotrexate and cyclophosphamide, the regimes are really good. So I think the message is to be on call with your pediatric rheumatologists.
The patients with nephrotic, what we had spoken with the medicine people, they say that when they get it's like an attack. When they get that, you have to give steroids. I mean,
and then send back to us immediately, so that we start with the Diamox
and everything. That's what.
Yeah, please, Julie.
So in steroid-induced, the optic disc is not very bad, but the pressures are going high, not getting controlled. So would you prefer to do an MIGS in such a patient? Rather than doing a trabeculectomy?
Yes.
Because in one child I did a GAT, because I had to operate both eyes, one eye trab, the other eye GAT. The GAT eye is still doing very well because he had total cataract.
So this is, I think, a trabecular meshwork problem, and here the GAT does very well. Angle surgeries do very well. I would think so, but you don't need to do
steroid-induced glaucomas.
Because
especially in VKC, the conjunctiva being so difficult to handle, they GAT does very
I think because the outflow is okay, rather than in PCG and JOAG. So the predictability of an angle surgery is better because once that trabecular meshwork is out, then the outflow is better.
So
I think
but in our clinic, sometimes the patients come at a very advanced stage.
Yes, then we have to.
Then we'll have to do trab also in such cases. GAT you can do, but otherwise they come in very advanced stages, most of them.
I would just like to say that, steroid-induced glaucomas are self-limiting. So if you can stop the steroids and keep the IOP controlled, in mild glaucomas or moderate glaucomas, most of them come back to normal. It's only the ones with 0.9 where you have to actually bring the pressure down.
Correct. So this is the last 2 minutes. We've already talked of following cataract surgery. Is it common? We've agreed it's not very common, I think. Who is most susceptible? This Dr. Sunita brought out, but we now know that less than 6 months if the cataract is out, because the lens is a regulator of the trabecular meshwork till about 8 or 9 months, those are the ones which are the most susceptible. And of course, syndromic and infections are the ones which are more troublesome. The idiopathic ones are less. And how to treat them, we've decided that Dr. Shanta puts in tubes, Sirisha does a trab, Sunita would do angle, possibly, or Julie would do angle. So to each his own, but as long as we get the pressures down.
Also, ma'am, we have seen that in patients, pediatric patients, less than 6 months, the lens have been put. Those patients do develop, this is what we have seen, they
glaucoma
have a higher,
much more. Absolutely, less than 6 months. Because
secondary IOLs.
And the IOLs.
Point, I think that Dr. Shanta's paper also, like microcornea, and microcornea is the predictor. And even infant aphakic study, they don't suggest that pseudophakia or aphakia makes a difference. But I don't know, like we have seen more glaucoma in aphakics than pseudophakia, but there is no difference in the incidence in aphakics and pseudophakics in infant aphakia study.
Yeah,
so
IATS actually said age is the most important.
Age. Less than 6 weeks.
6 months.
6 weeks.
6 months. 6 months is the whatever. So.
I think 45 days and whatever it is, and microcornea.
So I guess thank you very much. We'll wind up because we are way out of time, and thank you for just having a lovely discussion amongst ourselves. Thank you, ma'am, for your inputs.
We'll have a picture and then
we'll have a picture.